Okay.
Hi, good morning, everyone. My name is Navid Ghahermani. Today, I'm going to present to you the subject of ataxia, the degenerative disease of the cerebellum and cerebellar-associated neuropathways. Here's an outline for today's, starting with the modes of acquisition, going all the way to some in vivo molecular signatures. On the spectrum of the ataxia, whether it's acquired or inherited, on the acquired part, our main organ system that we are concerned is cerebellum. So a stroke, TBI, viral or bacterial toxins can attack cerebellum, and there are inherited conditions that also affect cerebellum. In any cases, history and physical examination are paramount. A thorough history taking is paramount to establish relevant differentials. Now, differential diagnosis, there's plenty of them, starting with Friedreich ataxia, Fragile X-associated tremor, ataxia syndrome, and many, many more, which we are going to discuss today. Basically, ataxia symptoms are lack of coordination, trouble eating and swallowing, heart problems, that is the genetic door, that's where the genetic door opens, slurred speech, tremors, difficulty walking. But it's best to take a look and just get an idea how it actually looks. So let's take a look together on this one. Here's a person known with ataxic condition. Take a look. Difficulty of heel to toe, difficulty finger to nose. And when there's coordination of the eyes, when the finger moves of the doctor, then it becomes more difficult. So this points out to the organ of cerebellum. Once cerebellum and all the pathways that leads to cerebellum are affected, there will be fasciculation, there will be unwanted movements, okay? Let's take a look at the eye movement. There is a nystagmus component of ataxia, where on this case, it's actually mild. It is present, but is mild. Let's take a look. So on this patient, the nystagmus component is present, however, is very mild. Deep tendon reflexes are affected due to dorsal column medial lemniscus involvement in ataxia conditions. The spinal cord is affected in ataxia. And positive Babinski is also part of the sequelae. This is another patient with ataxic condition. She has that typical doll's eye movement on the examination. So let's take a look. Oh, we didn't see that. This is a very clear nystagmus. Please take a look on, right. And you can see one more thing in this sclera. If you can point out, this is a known condition, which we're going to go over. These are telangiectasias. We're going to go over that, but I'd like you to see the nystagmus component. Here's a doll's eye movement. Take a look. See how the eyes lag motion, following motion, coordinated motion of the head. Okay. This problem can also be seen in various other conditions. It's not specific. And this is the point of my lecture, actually. We are going to make some specifications, how to look for what. So clinical presentation, on physical examination, there will be gait ataxia, impaired sitting and balance. There is gazed evoked nystagmus, dysarthria, intention tremors, dysmetria, and dysdiadochokinesia. We're going to go over that. Now, nystagmus is a very interesting finding in the field of medicine where can actually be confusing. Nystagmus can be a component of BPPV, but ataxias are sequelae of cerebellum. So if you can see, and please take a look at this diagram in a broad way. You see vestibular apparatus, you see brainstem, and you see cerebellum. There are multiple modules that lead to cerebellar output of its final motor response. If each of them are affected, there will be gait disturbances, and then there is balance problem. So the perception of balance is formed after it runs through the lens of vestibular apparatus, brainstem, vascular contributions, extraocular muscles, pupillary defects, medial lemniscus fasciculus, Edinger-Westphal nucleus, and cerebellum. And even after cerebellum, there's demyelinating conditions that affect the balance component. In this diagram, we can see there's anterior and inferior cerebellar artery. One branch comes out, and that's a labyrinth artery. Vascular problems can confuse vestibular difficulties with cerebellar ataxic. So it's our job to differentiate. Also, extraocular muscle defects can confuse the physician whether this is a vestibular or balance basically a balance problem from a vestibular system, or it's a cerebellar system. So this is our job to differentiate well. So origin of ataxia, is it vestibular or is it cerebellar? From the eye's point of view, nystagmus defines this very well. And nystagmus originated from cerebellar pathology is not manipulated by Dix-Hallpike or Lampet maneuver, whereas in conditions such as BPPV, the otolith can be dislodged and be manipulated. So this is one way we can approach as clinicians for a fast observation or solution. Let's take a look at our first case. Let's take 30 seconds or 20 seconds of silence and read the paragraph. Now, in this case, we can see that there's a 13-year-old female from Switzerland present with clumsiness and constant falls. Then the patient has deficit in position and vibration sense. There is intact P&T, there's kyphoscoliosis, and MRI of the brain and the spine is performed. Does not show cerebellar problem, but it shows atrophy of the spinal cord and medulla. So the systems that lead to cerebella can also create confusion for cerebellum. So there's early age onset, it is progressive, kyphoscoliosis, DCML, deep tendon reflexes are issued, and MRI was also performed. So on differentials, this case most likely is Friedreich ataxia. On Friedreich ataxia, one of the most common hereditary ataxias is an autosomal recessive mutation in frataxin gene on chromosome 9 with trinucleotide repeat GAA, and frataxin is a mitochondrial protein involved in iron regulation. What I'd like you to take from this page is the fact that component of kyphoscoliosis is somewhat unique to Friedreich ataxia, and where it is the most common hereditary ataxia where you're going to land on in clinic, usually present in adolescent years. There is a staggering gait, frequent falling, and on musculoskeletal deformities, you could observe pes cavus, hammer toes, and kyphoscoliosis. On evaluation, there's plenty of modalities for evaluation, but MRI of the brain would be wonderful to exclude other causes, to look for cerebellar atrophy if it's there. But genetic testing is very important to look for frataxin and GAA repeats. Video nystagmography is a little bit of an overkill for this condition, somewhat obvious, but performing ECG is vital for the patient because they often die from cardiac conditions. Reticular hypertrophy and inverted T waves are your best bet to take a good shot at this condition. Type 2 diabetes is also early age for young patient, kind of uncommon, but then the complication arises. Now, multiple system atrophy type C is our next condition. I'm going to go over some MRI. If you take a look in here, so note narrow, let me see if I can have, yeah, okay. So yes, there you go. So note the narrow middle cerebellar peduncle. This is, what is that? Okay, so here is a narrow cerebellar peduncles. So our multiple system atrophy type C, where it is a flare type MRI, there's pontine and cerebellar atrophy. So there is, my pointer, there's cerebellar atrophy, and then there's pontine atrophy. There's a hot cross-bond sign, which I'm going to show right now. So please take a look in here. This is what we call it, the hot cross-bond sign, the cookies. This is seen, it's typical. You can see it in here on the MRI. So that points out this MRI would be diagnostic for multiple system atrophy type C, a form of ataxia. On Fragile X tremor, ataxia syndrome, FXTAS. On FLAIR, the image of the brain showing high signal in the middle cerebellar peduncle. So here are middle cerebellar peduncles. And from this MRI, you can tell that this patient most likely has Fragile X tremor ataxia syndrome. So high signal in middle cerebellar peduncle in this case. The next one, on Friedreich ataxia, please take a look how narrow the spinal cord is. So thinning of upper cervical cord is diagnostic and a good indication that you deal with Friedreich ataxia on T1 MRI. Now I'm going to go over some clinical pearls. Clinical pearls are specifically for each condition in order as written on this page. Ataxia telangiectasia, you will have corneal spider angioma, as you can see in the picture. This is one of the conditions that strabismus and nystagmus at the same time show up. The child would have primary immunodeficiency, BNT, specifically IgA deficiency. So you will have repeated otitis media infection on a child whose eye has telangiectasia and has gait disturbances and is unable to repair, and so the condition is genetically is unable to repair double-stranded breaks in DNA before cell division. All right. And in the end, MRI will show cerebellar atrophy. So not all ataxia have cerebellar atrophy. This condition, ataxia telangiectasia, has the telangiectasia, has the cerebellar atrophy with IgA deficiency, with immune deficiency on the child. Fragile X, affecting mostly men, and it has the sequelae of tremor, ataxia, dementia. So let's take a look. If you, this is a clinical pearl is here, consider FXTAS in a patient diagnosed with essential tremor if they develop ataxia and Parkinsonism down the line. So if you had a tremor patient, now he's ataxic, then he looks like Parkinson, then he looks like dementia, then you could actually run a test, genetic, for Fragile X for him. Their grandchildren, you can ask question on history. You can say if your grandchildren has intellectual disabilities or if their daughter had early menopause in fertility. Genetic testing is suggested. For tremor, you can always treat with primidone and propranolol. Friedreich ataxia, take a look for scoliosis, hearing and vision loss on early age, young people, that's uncommon. So someone with ataxia, hearing vision loss, that's there. Deep tendon reflexes of two types. And so the reflexes are reduced in Friedreich ataxia, in ataxia associated with vitamin E deficiency, ataxia with oculomotor apraxia type 2. DTR are brisk and strong and dominant spinocerebellar ataxia, and multiple system atrophy type C. Infection etiology, look for HIV, Creutzfeldt-Jakob, and progressive multifocal leukoencephalopathy. These are top 3 differentials for that. Multiple system atrophy type C, please expect impotency and postural hypotension with urinary urgency and incontinence. So it becomes a little bit of internal medicine. Infantile Refsum disease, there is elevated plasma phytanic acid, which comes from the serum test. And from lumbar puncture, you can find peroxin 1, peroxin 2, and peroxin 26. Expect growth and developmental delay hypotonia, and deafness. There's facial dysmorphism, retinopathy, and osteoporosis. Those stand out. Cognitive contribution of cerebellum. This is very interesting. A primary cerebellar injury is in a premature infant has shown to be associated with contralateral decrease in cerebral volume, which means a closed cerebellocerebral loop is found in the prefrontal cortex. To this point, I personally never thought about cerebellum as having cognitive effect. Apparently, there's a concept called ontogeny recapitulate phylogeny, and it sometimes shows up correctly. However, it's disproven in philosophy and other fields. It seems like here is correct. Cerebellum itself doesn't have that cognitive aspect. However, its presence and its physical appointment to the brain prefrontal cortex it enables brain prefrontal cortex contralateral to actually evolve. So cerebellum provides a forward model of mental function in the cerebral cortex. The cerebellocerebral loop concerned with motor function develop. So I found this fascinating and wanted to include that. Postural swades with cerebellar lesions. Depending where the lesion in cerebellum is, if it is a stroke or if it's ischemic or traumatic brain injury, it has different consequences. I'm just going to read, I believe the most interesting one, the most common one is the middle cerebellar. So balance deficits as a result of a lesion in middle cerebellar structure, vestibulocerebellum, lead to a low frequency, high amplitude postural sway without a preferred direction and without intersegmental movement. There is in vivo molecular signatures for cerebellar pathology in spinocerebellar ataxia type 3 and acetyl aspartate and acetyl aspartate, myoinositol, and total choline level in the cerebellum are candidate biomarkers of neuraxonal and oligodendrocyte pathology. In SCA3 aspects of the pathology that are reversible by RNA inhibitor therapy. In the end, TP53 ATM co-mutation might help guide lung cancer immunotherapy. So what does that mean? Apparently, people who have two mutation of the P53 and ATM at the same time, they are more responsive and they have a greater overall survival rate that they reply to the cancer therapy. So TP53 and ATM co-mutation was associated with significantly better overall survival than a single mutation and no mutation among patients with any cancer. So they had a group of cancer patients, lung cancer patient, and some of them had P53 mutation, some had ATM mutation, and then some had both. And when they were giving them the medications, people with double mutation, they performed better on the survival. So this became an interesting aspect of ataxia. This is my references, and I really appreciate your time. Thank you.
Thank you.